Hey, everybody. So I'm Eric Moyer. I'm a clinical informatics fellow at Rush University Medical Center. I'm also an emergency medicine physician.
My name's Donald Wright, also an emergency physician, also an informatics fellow in my case at Yale. And today we're going to be talking to you about Cosmos, which is a cool emerging research tool.
So this is our kind of agenda for today. I'll kind of do the first half talking mostly about Slicer-Dicer, and then Don will come in later and talk about the DSVM. We'll start with an introduction, as I'm sure while some people here might be very familiar with Cosmos, there might be some who have never heard of Cosmos at all. And so we're hoping to give a little background, talk about Slicer-Dicer within Cosmos, the benefits, limitations, some example studies that I've been a part of, as well as a pseudo demonstration, and then we'll transition over to more discussion about the DSVM with Donald. Let's see. All right. So in case anyone has no idea what Cosmos is, I figured we'd start kind of with the basics. Cosmos is Epic's federated data platform providing access to de-identified patient data with the idea to foster some collaborative research. All the data within it is HIPAA compliant and de-identified, ensuring patient privacy. And as you can see with these stats I pulled maybe a couple days ago, so this is pretty recent, Cosmos offers a pretty significant amount of clinical data for very high-powered research. So as of a couple days ago, this includes over 300 million patient records, over 15.7 billion encounters across over 1,700 hospitals and 40,000 clinics. You can access the data mainly two different ways in Cosmos. One is kind of the user-friendly Slicer-Dicer interface, which is kind of more what I'm familiar with, and then the more technical data science virtual machine, where, we'll discuss about this later, but it allows for SQL queries and more advanced data analysis using your coding language of choice, whether that's R or et cetera. The DSVM does have de-identified patient level data, which is kind of one of the key distinguishing factors, but we'll discuss kind of that later. So moving on to Cosmos Slicer-Dicer. Slicer-Dicer is very similar to the Slicer-Dicer that you would have on your local Epic if you've used that at all to kind of analyze the patients at your institution. But essentially, it's a intuitive, user-friendly interface that allows healthcare professionals to explore the data without programming skills. So you don't need to know SQL to run your own queries. In Cosmos, there's predefined data models that you can look through. So whether this is patients or encounters, or in our case, ED encounters, you can look through, among others. You can filter by demographics or diagnoses, mainly through ICD-10 codes or SNOMED codes. You can look through medications, procedures, and procedures being mostly through CPT codes or ICD-10 PCS codes. You can look at, some common lab results, ED-specific metrics, so things like throughput, ESI, arrival method, arrival time, day of the week, et cetera, as well as some social terms of health. And I'm going to show a little bit kind of example later on, but it also allows you to generate bar graphs, line graphs, scatter plots, tables as well pretty easily without really having any sort of programming knowledge. I put three pretty typical use cases that we've come across. First, it's pretty ideal for kind of epidemiological studies. You can track disease prevalence, identify risk factors, and monitor population level health trends using diagnosis codes. Cosmos data they do backload data. So there is data that does go back pretty far, like in the 1990s. I mean, you might not have a lot of it, but it is there. But have been using, for like my research team, 2016 as a cutoff, since that's when ICD-10 codes really came about. So second, it obviously can aid in clinical research, help you generate hypotheses, identify potential study cohorts, and perform preliminary analysis that can help guide formal research, for example, within the DSVM if you wanted to do more advanced analysis. And then lastly, something that could be done as well, given that Cosmos has throughput data in its database, you can compare your institution across others nationwide. For example, if you want to compare boarding times or ESI data, you could do that as well. And basically the benefits lie with Slicer-Dicer in its accessibility and efficiency. You can retrieve and analyze these massive data sets in minutes. It doesn't take weeks. Also, within Slicer-Dicer, you can queue up multiple queries concurrently and then let it run in the background while you do other things, come back to it, and then look through the data so you're not having to sit there and wait or anything like that. It's highly accessible, does not require any programming expertise, although how you export from Slicer-Dicer is through Excel, and maybe some Excel knowledge would be beneficial, but otherwise no programming expertise required. And kind of like how we touched on, it's access to kind of these unprecedented sample sizes. I mean, you're looking at hundreds of thousands, or in some cases, millions of patients or encounters. Depending on the study, IRB approval may be necessary, especially with the DSVM, but some of the epidemiological studies we've done previously were deemed exempt, so that's a very easy process. And once you have your own workflow, we've been able to gather data and analyze it in days. The longest part that we run across is setting up the queries, but then also writing the manuscript ends up being the longest part of it. So pretty quick turnaround for some of these. But it's important to know kind of some of the limitations of Cosmos, specifically Slicer-Dicer is what these kind of limitations are for. But in Cosmos, one of the benefits, I guess, is that it's constantly updated. So new encounters, new patient information is constantly being added to Cosmos, which can be good, but it's also one of the limitations is that the Cosmos studies, it's pretty much impossible to replicate or validate the studies because the patient data is always being updated. It probably updates every 1 to 2 months, if not maybe a little bit more, like sooner. And so that's difficult also if you need to re-pull your data to reanalyze, or if there's a reviewer comment that wants you to look at something different, then depending on when the last update was, you'll have to re-pull all of your data, which can kind of be tough. Second, so Slicer-Dicer offers limited ability to control for confounders in these kind of retrospective observational studies. The DSVM does improve this as you do have access to line level data, but in Slicer-Dicer, that is a big limitation. Thirdly, so reliance on ICD code is not always perfect, as I'm sure everyone here can probably attest to in the emergency department. We're not maybe coding every single thing every single time. And so the data from Slicer-Dicer does rely on some of these, so it may be imperfect. And so there's a potential where some conditions are miscoded or undercoded. And then lastly, Cosmos data is originating from participating EPIC institutions. And so it may not represent all healthcare settings, and that does maybe select for more research-oriented institutions, and there's a potential for skew of the population you're analyzing. And this is a slide mostly just to show some examples of what we've done at Rush. There's a few of us on the team, me included, but three studies that we've put out. So one is a epidemiological study that examined PE encounters in the US emergency departments over an 8-year period. We're able to analyze trends in anticoagulation, fibrinolytic usage, CT utilization, and then kind of the demographics of the cohort. Another study we've done was we looked at disparities in troponin and EKG testing among emergency department patients in the US, looking at basically a cohort that did and did not receive these tests, and while controlling for some demographics. Of course, it's a little bit limited in Slicer-Dicer, but we're able to do this as well, publish that. And then most recently, we kind of explored delays in diabetes diagnosis for emergency department patients who present with a glucose over 200, looking at, how many go to develop DKA in the coming months, or how many do end up getting diagnosed formally with diabetes in the coming months, even if we don't ourselves make the diagnosis in the emergency department. We've published some of these in American Journal of Emergency Medicine, Academic Emergency Medicine, Journal of General Internal Medicine, and then also Clinical and Experimental Emergency Medicine. So publishable studies can come from Slicer-Dicer, definitely, but again, there are some limitations that we already talked about. And so I wanted to go through a little bit, just an example. So this is just a screenshot of some data that we got during one of our other studies looking at cystitis and antibiotic usage. I know it's a very busy slide, so hopefully I can make it a little bit digestible. So to start, to build your query, the second column where you can see population, slices, measures, dates, and visual options, that's how you kind of build your query. So in the population section, you'll see that we're looking at ED encounters. And then on the far right, the specifics of the ED encounter. So we're specifying an ED diagnosis using a grouper that we created using ICD-10 codes. I just labeled it cystitis, but it's a group of ICD-10 codes, the age, so 18 plus, so adults, in the United States, and then who were never admitted. So that's your kind of your population. Then we sliced it by prescriptions that were prescribed. So on the far left, you can see the 10 slices essentially. So macrobid, Bactrim, cephalosporins, etc. And the measure being number of encounters. So within the table, you'll see, for example, in 2024, the total number of encounters that met these criteria was almost 1.5 million encounters. So we're looking at huge amounts of data here. And in that year, you can see how many encounters the patient was prescribed macrobid or a first generation cephalosporin. And this is from 2017 to 2024, looking at it yearly. I showed this slide. If you do end up wanting to do some research in Slicer-Dicer, it's important to know that this is the format you'll need to be able to export it to Excel. So in the bottom right visual options, you can see you can do bar charts, you can do line graphs, you can do scatter plots. But on the far right is the table or crosstab format. And then if the table type you select crosstabs, you can right click on the table and export it to Excel. And then in the Excel document, it'll be this exactly. And so then you can run your analysis however you want. And then we can get to, so this was what was published in our study for this, using the data from the previous slide. This is what we published. And so you can see the trends. There's an increase in cephalosporins and a downtrend in ciprofloxacin, macrobid, Bactrim, et cetera. And so you can get publication ready images from the data that we had on the previous screen. Another example I just wanted to show, this wasn't from a study, this was just me playing around. But so if we go to that second column again, we can see the population. We're looking at ED encounters in the United States. We sliced it by acuity. So on the far right, you can see level 1 through 5, like we're all accustomed to. And then I looked at median arrival to room from 2016 to 2024, and we just showing it as a line graph. And so you can see level 1s get roomed within 1 to 2 minutes. And then as the acuity increases, the wait is longer, which kind of makes sense. As I was exploring, I started with average, but the averages were a little off. And so one thing you can do is you can kind of investigate why median might be better than maximum or by average. And so using the average, it was including some of these maximum values. And so you can see that for some encounters, they're saying the arrival to room time was over 60 million minutes, which is obviously impossible. My guess is a patient left without being seen and the timer never stopped. But it's these sort of cases where then you can go into the DSVM, explore a little bit deeper and understand your data, what you're looking at a little bit easier than you can in Slicer-Dicer. And so this was our transition.
Thanks, Eric. Yeah, so I'm going to be talking about the data science virtual machine, which is the other way you can use Cosmos. Next slide. So just to provide a high-level comparison of Slicer-Dicer versus the DSVM. So as we already discussed, Slicer-Dicer is a user-friendly interface. It doesn't require much training to use. It doesn't require any coding knowledge other than basic understanding of Excel. And so it's a nice low barrier to entry for projects. At many institutions, you're not going to have many barriers to getting a new project going, aside from putting in a disclosure statement in Cosmos and starting looking at data, essentially. And there's no necessary mandatory pre-review of the data that you extract by Epic. As part of the Cosmos rules of the road, which is the kind of big overarching rules of using Cosmos, all institutions are required to periodically report all of their publications to Epic, but you don't need to pre-clear any of your data with Epic when you're using Slicer-Dicer. With the data science virtual machine, it's a little bit more complicated. You're going to need team members who have expertise with SQL, which is a query language for interacting with databases, and generally either R or Python. There is still some Excel in the data science virtual machine, but the vast majority of cases where you're going to want to use this, you're going to want to use a different mechanism of dealing with large data sets, because we're going to usually be talking in million row intervals. Going on from there, you do get de-identified line level patient data access. This does have some training requirements, which do come with cost. A note for the physician builders out there, if you're an active builder and you build at least 10 hours, I believe within 6 months, then you qualify for a fee waiver on further training with Epic, which you can use on these courses. So just something to be aware of. The courses are offered virtually. And then the data exports from the DSVM do require a manual processing step by Epic. What that consists of is they review the data that you're planning to take out of the DSVM, and they're looking for two things. One, they're making sure that you're not trying to re-identify individual patients. And second, they're also trying to make sure that when you are exporting the data, you're not creating the possibility to calculate the size of any cell less than 11 patients. And this is part of the definitions of the HIPAA safe harbor rules that allow for Cosmos to exist. You can't have small cells that could potentially re-identify individuals. Next slide. So just to introduce, and this slide does contain intellectual property of Epic. They reserve their rights and have given permission for us to use it in this context. We have the kind of an overview of what different things exist. So we had already talked about Slicer-Dicer, which is the kind of first tool that most people are going to use when they're dealing with Cosmos. But if you're getting into the rest of the tools, you're going to have access to SQL Server Manager for doing database maintenance. You're going to have access to Python and or RStudio for dealing with your code base. And then there's also some collaboration tools, including GitLab and VS Codium for setting up collaboration setups, particularly between different individuals working in the DSVM for managing data, just because these projects can be fairly complex and oftentimes involve lots of moving parts. A common question that generally comes up is which code libraries are available, since this is a siloed environment. All of the major ones that you're probably used to using for those who code in either R or Python are there. Tidyverse for the R, all the major tidyverse packages, including ggplot, are there. And then on the Python side, there's pandas, things like that people generally are looking for. Next slide. So diving into why you would use the data science virtual machine, I think there's a couple crucial cases where it really becomes important. One of them that we already talked about is if you're seeing kind of inconsistent findings between what you're seeing and what you know about the world. If there is either previous literature that suggests something different than what you're seeing in Slicer-Dicer, or if what you're seeing in Slicer-Dicer isn't consistent with your clinical experience as a physician, that should prompt you to look for potential outliers or other explanations, and that means a trip to the DSVM usually. If you have extreme results like really strong correlations that almost look artifactual, if you're seeing outlier data points like we were talking about there, where you have 8 million minutes, something is clearly wrong there. And there are ways to diagnose that in the Slicer-Dicer system, like looking at max values, minimum values, but your ability to interrogate all of the data points is really not there in Slicer-Dicer. You do not have the ability to look at every individual that is in the aggregate that's being reported. There are strategies to get around that with segmenting your population and looking at, are there nonlinear trends within that population that might indicate something is going on? But once you start getting that suspicion, going to the line level is usually your best option. And then the final area, and this is something that I think comes with experience working in Cosmos as well, is that there is variation in the quality of the data. Like any federated system, there were rules around how this data got into Cosmos. There is an upload process of how the data is ETL'd up to Cosmos, and there are norming processes that are involved in getting the data into a format that is usable for combining with other Epic institutions, because every Epic institution does things a little bit differently. And especially those who've been on Epic a long time may have relatively customized setups that are a little bit different than vanilla Epic. And so because of that, particularly in areas that are already prone to variation, like laboratory data, there's the potential for significant variation and potentially non-random missingness. And so that if you suspect that's going on, this is another area where the DSVM can help you investigate that, particularly if you have a statistician. Next slide. A couple areas where the DSVM is your only option. If you want to do regression modeling, you're going to the DSVM. because you're going to need line level data in order to look at interactions between different participant level characteristics. If you want to look at doing machine learning, like building an XGBoost model, things like that, you can do that in the DSVM. You can't do that in Slicer. Well, one note here is particularly if you're building more complicated machine learning models that have many weights involved, exporting those may or may not be possible from the DSVM, just because once you have a certain number of weights, the risk of identifiability of individual patients becomes relatively high. And then if you want to do more complicated statistical analyses, if you want to open up R and do a lot of math on your patient population, that's generally going to involve a trip to the DSVM. And we've already discussed cohort validation. Next slide. Before we dive into a little bit of the training pathways, I think it's just important to note here that particularly when working in the virtual machine, interdisciplinary teams are really helpful. And that's been my experience at Yale, where we have a team that is mixed of data scientists and emergency physicians and statisticians. And when you need so many different skill sets in the same room, you're going to have some people who come from an informatics background that can bridge that gap. But most people are probably going to be most comfortable either in the defining the clinical question side of things or in the processing large amounts of data side of things. And those are oftentimes different skill sets that don't fully overlap. And so finding and building collaborations with, if you have an informaticist within your institution, if you have like a biomedical informatics or clinical informatics section within your institution, that could be really helpful. And oftentimes these are great projects for master's or PhD students in data science because a lot of them want to work long-term with healthcare data, and this is an opportunity to do that. So just outlining a little bit of the different user types that we have. So a general Cosmos user is the lowest level of access that you can get. This is for individuals who are going to be end users, primarily in Slicer-Dicer. And this generally involves doing a couple webinars, all of which are asynchronous, taking a quick test, as I recall, and then signing a user agreement. The super users is the next step up. This gives you some advanced training on Slicer-Dicer, a little bit of best practices, and gives you an actual little badge from Epic. And they like to see a certain percentage of your Cosmos population are super users. Researcher is kind of similar. It focuses a little bit more on data quality issues and is oftentimes a segue into doing either the data architect or data scientist tracks. These are the data architect and data scientist tracks. Again, this is a slide from Epic. These are virtual courses that are offered by Epic. They do require a payment from your organization, so you should check with your local Epic team and potentially whoever your contact point is for Cosmos at your institution if you are a Cosmos institution. And they generally will get you in initially in Cosmos 305, which is a general introduction, which is great for PIs as well as anyone who's going down this pathway of learning more about Cosmos as an introductory course. It's a big picture summary of what we've talked today, and it's taught by the Epic staff. If you go down the Cosmos 550 path, then that gets you the data science module. So that gets you access into the DSVM. It doesn't give you access to the database tools, but it does give you access to using R or Python to process data that someone else with the database tool has extracted for you from the database. And then the most intense course is Cosmos 500, which takes about a day and a half. And this is a very full day and a half of classes. And that goes into really in-depth how to build data sets in Cosmos from the main database and how to extract those into data marts, and then how to export those data marts for your data science colleagues to use in doing analyses. I come from a clinical informatics background, so I did all three of these, which I found really helpful. But depending on your particular role with your institution and whether you know SQL, that's going to be probably determining which of these you do. And we have one more slide that got cut in the middle, and that is this big slide showing all of the different data domains. This is not technically all of them, but I think they're the most important ones. This is another slide from Epic. On the upper left, you can see the demographics that are in Cosmos, the types of encounter information they have on the lower left. We have diagnosis information, various other clinical outcomes that you might want, social demographics around things like social vulnerability index for where the patient lives based on zip code, area deprivation index. All of this can be allowed for developing risk prediction models and things like that. Really helpful covariates to be able to capture. And these are generally cross-linked either at the patient level or at the encounter level with the patient models. that's all we have. So I'm going to transition over to questions and answers. So I see two questions are already here in the chat. So getting pre-hospital data into the DSVM, this is very challenging. So the immediate issue you're going to have generally with bringing other data into the DSVM is that there is no linkage because the patients are all de-identified. Additionally, the institutions are de-identified because part of the rules of the road is they don't want people using Cosmos for market comparisons between different institutions for their outcomes on surgery or things like that. And so because of that, while you can have Epic pull in other data sets for you to link on other things like state level data sets around like rates of other things that you may want to index against, generally linking at the patient level is not possible or at the institution level. And then if you are not at a Cosmos institution, unfortunately, you're not able to use Cosmos. This is part of the underlying rationale for the federation of the resource is that it's for the benefit of all of the organizations that are contributing to Cosmos. And so the way it's structured is there's a governing body. This is the overarching organization that is composed of individual people from the institutions that contribute to Cosmos. And they set the policies about how we're able to use it in conjunction with Epic. That was a long-winded answer.
Adrienne, go ahead.
Hey, first off, thanks for doing this. The question that I have may be very basic. I'm just kind of getting my first little bit of learning with Slicer-Dicer. And one of the issues that's come up on one of the projects that we're trying to work on is how to effectively parse through what has been added as a discharge diagnosis in the emergency department now that everybody's kind of throwing the kitchen sink at the discharge to meet the new billing requirements. How are you working in those situations to identify what was the true main discharge diagnosis for the ED population in Slicer-Dicer?
I think it's difficult. You can use the filter like primary diagnosis. Often that might not actually be the primary diagnosis, but that would be one way to see. We just end up using ED diagnosis just to make sure we catch all the encounters we can regarding whatever we're looking for. But I think what you're explaining is one of the limitations of using these sort of diagnoses as a way to, group your patients or create your cohort.
So is this in situations like that, would you recommend more working through one of the DSVM programs to get a better idea?
That'd be the ideal scenario, right? Because then you get patient level data. You can really tell. That's a hurdle, as Donald was talking about. Not everyone, it takes essentially money, but also time to do the classes and the expertise to code, et cetera. But that would be the ideal scenario. But sometimes we work within the limitations that we have. And so that's kind of what we've been doing. But
for sure.
It looks like we have a couple questions about the data models as well in the chat. T-Trex question about the outcomes. Death is very easy. The one thing I will say is when you're looking at mortality, you're only capturing mortality that either occurred in an Epic institution or is reported to an Epic institution. And so there is potential missingness on death. ICU escalation, transfer, things like that are also in there. You can tell based on what level of care they had at a given time. That area does get a little bit dicey just because when an admission is ultimately coded, it's coded based on the institution ID of the discharging institution, from my understanding. So you can end up with some weirdness, particularly when people are transferred between institutions or from like distant sites to central sites. And then there's a chief complaint question I see here as well. Chief complaints are there. One note here, the chief complaint model only includes structured chief complaints like chest pain, shortness of breath. Many institutions use custom coded chief complaints that they've added. Those ones, due to identifiability concerns, are not included. Additionally, you can end up with situations where the chief complaint has been free texted by the triage nurse. Those are also lost as well. One other note too, I got a message as well about results of imaging. There are no notes. There are no imaging results. Anything that is free text is not in Cosmos. And the reason for that is because they needed to de-identify everything, and the models for automated de-identification for free text just are not there yet. And so because of the volume of information that they have, the decision, as I understand, I'm not a representative of Cosmos, early on was to not pursue those free text sources.
then Benjamin's question, so is there data about which patients were seen by residents or medical students while in the emergency department. As far as I know, at least not in Slicer-Dicer, there is not a way to identify those. Done.
I don't believe so. There is some provider level information, but it's very sparse. And part of that is because individual Epic institutions maintain their own SIR IDs for tracking their providers. And there's some heterogeneity in terms of how those are recorded and how much data is available about the provider types. There is some data about providers, but I don't think it's super reliable. Then there was also a question about ICD-10 codes and records. You would not be able to get any of the data from the notes, unfortunately, but you would just have the actual coded information. The question was around extracting keywords, and unfortunately, there's currently no NLP, there's currently no large language models, nothing of that sort, though they do apparently have some GPUs, and they're doing some things in the background, so who knows, we might see something eventually.
I believe the ED population does include urgent care sites.
I believe they also have a visit type of urgent care, but I don't know how consistently those are used between institutions. The line gets very blurry around freestanding ED.
And then Professor Emmanuel, I see you have your hand raised. You can go ahead.
Yeah, and nice, the colleague. Thank you for the excellent submissions. I listened intently, and I'm quite amazed with some of your submissions. My add-on to some of your comments will be rather bordering on as to how we can have a trans-institutional policy review on Cosmos use because of the inherent limitations that are with Cosmos. We may have to set up a committee or a board to look at how some of these inherent limitations can be updated or revised to make it more user-friendly and to catch more sites and modalities. These are some of my areas of concerns now. Thank you so much, Moyer. Thank you so much, the colleague.
Yeah, and I think that's really where the council comes in. The governing council is composed of stakeholders from the institutions, and they contribute a lot of that thought around how to make this data resource better and how to make it more useful. Ideally, I would have loved to have one of them join us. They're just all very busy people, so they're hard to schedule.
Thank you, Wright.
And then zip codes based on income. You cannot generally identify zip codes. The lowest level I think you can get is 3 digits. Correct me if I'm wrong there, Eric, in certain circumstances. Generally, what you use if you want to look at income disparity is you look at the social vulnerability index based on, I believe, income for that patient. And then you can look at that as a covariate, as a stand-in for the zip code, but they don't want you to be able to re-identify people in like rural areas with rare conditions.
Yeah, I haven't used it too much, specifically zip codes. I know there is a zip code filter. I just don't know how like specific it gets or how that works. I haven't actually used it much, but
I haven't either. I know it's limited at least from the training. I haven't gotten into the geographics too much. The other thing is most of the information about the patient level location is a most recent value field. And so what that means is it's the field that is the most recent visit they've had. So for example, if you want to look at what state a patient lives in, you're not going to get the value for where they lived if the encounter was 3 years ago. You're going to get the one from this year, from when they had a different encounter. And so if you're looking at doing cross-sectional analyses about geographic variation in care patterns, oftentimes you would have to look exclusively in a narrow window of time.
And then to go back to Gina's question, so are you able to obtain total patient populations to create a denominator? Yeah.
And then there was a comment about the SES. So the SES is generally regional rather than patient specific. They have been adding SDOH elements. So I know this is changing. So they may be pulling in more structured patient level elements of the DSVM. I don't want to get ahead of, jump the shark on this one, but the area that's best built out is based on essentially mappings of social vulnerability across multiple different domains as defined by their zip code. So it's not necessarily patient specific, it's specific to where they live. It is prone to like ecological fallacy and all of those issues. So it's not necessarily a clear surrogate for having true patient level, patient reported social determinants, which I believe they're adding, but I don't know too much about the domain. I know it wasn't available in the beginning, that's unfortunately between it. And I think we missed a message from Gina about total patient populations. You can get counts in terms of how many people were in a population that you're looking at. For example, in the screenshot that Eric had, he had all of the patients who had a diagnosis of cystitis, and you have each of the antibiotic rates of how many got what antibiotic, but you also have the total number at the very bottom. And similarly in the DSVM, when you query, you're going to be querying generally like a number of encounters or a number of patients. And then you'll be able to also note then whether you have individuals who fall into multiple categories, which is doable in Slicer, but a little trickier. Any patient that has a zip code, there was a question about whether patients consistently have social vulnerability indexes. If they have an address documented, then they should have a SVI auto-populated based on their location. And yes, you can trend ED visits across a single patient over time. I think this is one of the biggest strengths of Cosmos that maybe we didn't emphasize enough earlier. Because Cosmos, the way the ETL works, when you are sending data about a patient to Epic, to Cosmos, it gets cross-linked to their Care Everywhere identifier, which gets hashed. And so that is an identifier that is really in the back end, really cross-linked to their social, and that persists between different institutions. So as long as that has been persisted correctly between institutions, which doesn't always happen, then an individual patient will only be represented once in Cosmos, and the same patient ID will be visible across all of their encounters. And so, for example, if you have a patient who's in Florida and gets hospitalized for a PE, gets discharged, goes back to Connecticut, and then dies in Connecticut at a hospital in Connecticut, you can see their mortality in Connecticut, which is really cool. If they happen to go to a Cerner hospital and it doesn't get reported by the state to Epic, which some states have cross-linking for that information to flow both directions, then you might miss. And I have no idea about whether they're adding national death indices, but that's a great question. Unfortunately, we are not representatives of Cosmos or the governing council, so I have no idea what they're planning other than what they tell us. We're users just like you. We're just here because we love this data source and want to share it with the community.
All right. Unless there's any more questions here, we can put our contact information back up just in case. Let's see.
And a final note, in addition to contacting us, if you are at a Cosmos participating institution and you want to get started with Cosmos, you should have a site contact for Cosmos specific to your institution. If you're unable to figure out who that is, you can talk to your Epic support people for your institution. And there's usually a technical support agent that's assigned for every institution by Epic, and they can also help you navigate that issue. If you are not a Cosmos site, but you are on Epic, you should talk to your IT people about maybe becoming a Cosmos site. There's a lot of steps involved to get there, but obviously it's got some huge benefits from a research infrastructure standpoint. And it's free as long as it's not funded research. You don't have to pay Epic for the data since it's yours.
I guess tips, I think Donald's kind of put it, but from a research infrastructure point of view and generating research, even just with Slicer-Dicer, which has that low barrier to entry, even non-researchers could get started with it. So I think that's a case to make to your institution. If they want more research being done, this could be an easy way for people to get interested in it and start projects. But I think that might be the case to make.
Yeah, really crucial question there about funding. So this is true of Cosmos, this is true of MarketScan, which is a similar data set as well. The way the funding works for Cosmos is that if you have an unfunded project or you're doing work towards sending in a grant, like prelim data, then there's no cost. If it is part of a grant that you are being paid for, then it needs to be included in the budget. I don't have exact figures on that. And in addition to that, any funded research needs to be reviewed by the governing council and approved to make sure it's consistent with the mission of Epic, or I'm sorry, the mission of Cosmos, not Epic. The other aspect of this that's important as well is that there are limitations on using Cosmos for commercial research. There really is an emphasis in the rules of the road that they do not want you selling Cosmos data to people who are not part of Cosmos. And so if you're approached by like a journalist or a pharmaceutical company to like get them data from Cosmos, that's generally not allowed.
Hey, Kyle, thanks for pointing that out too. There is development, like new features from Epic, such as like lookalikes or best care choices that do use Cosmos data. So that would be another, if you want to kind of stay up to date with the most recent Epic features, that might be another way to get your institution to buy in.
Yeah, exactly. This talk, we really focused on the research application, but when they talk about Cosmos, like when you go to XGM or other places in the Epic kind of world, they generally are framing it not only as a research tool, but really as a clinical care tool as well for benchmarking performance and finding similar patients for like rare cases, things like that.
No problem. Thanks for having us and organizing this. Thanks for all the
Thank
questions.
you, everyone. Yeah, and just a reminder as we close, none of this is official Epic speech. So if we said anything wrong and the information released by Epic is different, trust that information, not us.
Thank you both so much.